All right. So I think I'm going to go ahead and get started. Before I introduce our presenter, I do want to introduce Haley Van Vleck, who is our new AHA staff person. So we're super excited that she's on today, that we're getting to meet her face to face. Haley comes to us with experience with the Arabian Horse Registry Council. I know I'm not saying that exactly right. So she does have experience in the horse industry and with membership and with an association similar to ours. And Haley's also training a young Mustang. So I thought that was really cool. Okay, so I'm going to go ahead and introduce our presenter, Kelly Coney-Pacious. Kelly is a physical therapist with her doctorate in physical therapy. Kelly has over 13 years of pediatric experience in a variety of treatment settings. She has been incorporating hippotherapy into her practice full-time for the past 10 years. She's the clinical director at Shining Hope Farms in Charlotte, North Carolina. She is a PATH certified therapeutic riding instructor and a hippotherapy clinical specialist. She serves on several AHA committees and is about to be coming on as an AHA board member. Kelly and her husband, Paul, in her spare time, raised their 4 children and also raised service dogs. So we're very excited to welcome Kelly to talk with us about coding and billing.
Thank you, Carol. All right, let me go ahead and share my screen. All right.
Kelly, can I interrupt for just 1 second just to remind everybody, please put questions in the chat. I'll be monitoring them. And then if we feel that they're urgent, we'll interrupt Kelly. And if not, we'll hold until the end. Or you can just hold your questions and wait until Kelly's done.
Perfect. All right, so we're going to go ahead and get started. So the presentation today is called Back to the Basics, Coding, Billing, and Documenting Therapy Services. And as Carol already said, she, gave me a great introduction of kind of where I come to from this or for this. And really, I thought this was important and kind of posed the idea when we were talking about lunch and learn topics, because as the clinical director and kind of help bringing therapists on board to our facility, Shining Hope Farms, over the last couple of years, I find it to be a struggle point for therapists just to kind of come in and transition into our clinic, utilizing equine movement as part of their treatment strategy. So these are kind of just the things we've learned, or I've learned over the years on how to really code, bill, and document your therapy services, more from the therapist side of things, and what you really need to know to be successful, to get reimbursement and to make sure you're doing it correctly and effectively. All right. So the learning objectives for today will be that participants will identify at least 2 CPT codes or HCPCS level 1 codes for PT, OT, or speech that would accurately depict treatment utilizing equine movement. Participants will be able to identify and define a HCPCS level 2 code. Participants will be able to define appropriate documentation components to support coding, and participants will identify common documentation mistakes. So before we kind of go into the coding, billing, and then documentation, I wanted to review quickly what everybody on here, I'm assuming, already knows or has an idea of, but just what the description is of hippotherapy. So American Hippotherapy Association, of course, has this on their webpage, but the term hippotherapy refers to how occupational therapy, physical therapy, and speech language pathology professionals use evidence-based practice and clinical reasoning in the purposeful manipulation of equine movement as a therapy tool to engage sensory, neuromotor, and cognitive systems to promote functional outcomes. Best practice dictates that occupational therapy, physical therapy, and speech language pathology professionals integrate hippotherapy into the patient's plan of care, along with other therapy tools and/or strategies. So this is going to be important to remember as we go on, just because we are still going to be our disciplines first. So PT, OT, or speech, and using equine movement as one of our therapy tools in our plan of care. So again, we know that indications or benefits of hippotherapy. So the clinical populations we might be seeing would be patients with mild to moderate neurologic, sensory, oral motor, communication, or motor deficits. And then we all know that impacts a lot of different systems in the body, or that we're going to have different reasons that we're going to clinically use it to meet those functional goals. So depending again on your discipline and what your functional goals are, they might be some of the things listed on here or some other things, since we know there's a lot that we're impacting when we're utilizing this as a treatment. So arousal and attention, neuromotor function, bilateral integration, muscle strength, sensory motor integration, respiratory function, oral motor function, postural stability, and balance. So we're going to move into, now that we've just kind of reviewed what we're looking at and why we would be using it, is coding and billing of these services. So we're going to start by talking about medical billing codes. There's the Healthcare Common Procedure Coding System, and this is referred to as HCPCS. It's a set of standardized healthcare procedure codes based on the American Medical Association's current procedural terminology, CPT. It allows providers to submit claims to healthcare insurers or third parties in an orderly and efficient manner. So prior to the creation of this system, there were hundreds of different terms that could be submitted by a provider in order to try to gain reimbursement, but it would be for the same service. So this system just allowed for better communication and clarity on what those services were and how to submit them for reimbursement. The HCPCS is divided into two principal subsystems referred as level 1 and level 2. There is a level 3 that really isn't relevant, but I do mention it in case you see it out there. We're going to go ahead though and move into each of these a little bit more for discussion. So HCPCS level 1 is going to be the most important for us and where we're going to really want to focus. So the level 1 of HCPCS is comprised of the CPT codes. So again, the current procedural terminology, and it's a uniform numeric coding system that's maintained by the American Medical Association. It's comprised of the CPT codes, and it's used for descriptive terms to identify the codes that are used primarily to identify the services or procedures that would be completed by physicians or other healthcare professionals. So we would fall in this as the other healthcare professionals. These healthcare professionals or physicians use the CPT codes to identify the services and procedures for which we bill, both to public and private health insurance programs. The decisions regarding the addition, deletion, revision, or any changes to the CPT codes are made again by the AMA, and those are updated annually. It's also important to note that these codes are supported by our organizations that represent us, so the APTA, the AOTA, and ASHA. So once again, this is where we fall under where we should be billing and coding for the services that we're providing within our scope of practice. So then we're going to talk about the HCPCS level 2, and we're going to move into these a little bit further on, talking specifics about each of these HCPCS levels. But the HCPCS level 2 are pretty much codes that are not covered by HCPCS level 1 or the CPT codes. So these codes are used to identify products, supplies, and services that, once again, are not covered in the CPT codes. So typically this is things like DME, so durable medical equipment, orthotics, prosthetics, ambulance services. Once again, things that are not covered by the services provided by a healthcare professional. The codes for the HCPCS level 2 are going to start with a letter, and then they're followed by numbers. The HCPCS level 2 codes are not maintained by AMA, so they are not updated annually by them. They're not organized by them. There are no changes with them. They're actually updated quarterly by CMS. And then it's also important to note that the HCPCS level 2 are often can be listed also as experimental. So we're going to talk more about that later on. And then I mentioned the HCPCS level 3. So these are more local or regional codes. They have been around since the early 2000s when they were developed, but they're not presently in use. So we're going to go back to the CPT code. So once again, the HCPCS level 1 codes that we should be talking about. So for best practice, the AHA does include a resource paper on their website that you can look at for best practice statement. And it gives you an idea of where, depending on your discipline, are the most appropriate codes to utilize when you're incorporating equine movement into your treatment. So I've listed them here on the slide. Just, of course, you'll notice some overlap between disciplines, but they're divided upon disciplines on where they would fall and what codes would be possibly the best for using when you incorporate hippotherapy. It's also important to know that, once again, since these are updated annually, you can go ahead and request, it's for purchase, but a CPT code book that comes out every year. So that's another resource as well as you need that. So why these codes? Once again, we're going to always refer back to that there's never one time when we stop doing whatever discipline you are, whether it's PT, OT, and speech, and start doing something with the horse. So, you know, where I am, we typically see patients for an hour, and there's no point that when I transition and go out and start using the horse that I stop doing PT and I start doing something else. So it's really important to remember that when we're billing and coding, and go back to the codes that are relevant for our discipline. So knowing the definition of those CPT codes is going to be really important to drive what you're coding and how you're documenting it. So going in more in depth into the codes and the descriptions, which is important so you can support your treatments and then also support that with your documentation so that you get reimbursed. So 97110, which is therapeutic exercise to develop strength and endurance range of motion. 97112, so neuromuscular re-education. So for looking at movements, balance, coordination, posture. 97116, so we're looking at gait training. This would also include stair navigation. 97530 for a therapeutic activity, so use of dynamic activities to improve your functional performance. 97535 for self-care or home management, so things including daily living tasks or ADLs, meal prep, safety procedures, compensatory strategies, adaptive equipment, things like that. On the next page, we move more into the speech language codes that would be appropriate for billing and coding. And when we talk about these, it's important to remember that these are not time-based, like for the physical therapy or occupational therapy CPT codes. And we'll talk a little bit more about the time-based and the units later. So those are just a unit base. So the 92507 for treatment of speech, language, communication, or auditory processing. 92508, 92526 for treatment of swallowing dysfunction or oral function in feeding, and then the 97129 and 97130 for therapeutic interventions that focus on cognitive function. So of course you guys could go back and read more about that or look it up at the resources I listed, but the important part here again is going to be that you need to really support your documentation for reimbursement and to know what you're billing is to know the definition of your CPT code. So it can help you identify what you're targeting as a skilled therapist, as well as where your documentation needs to go. So again, looking at the definition of your codes to determine which might be the most accurate to utilize, and then also to support your documentation. So knowing your codes, like I said on the previous slides, is very important. Remembering other factors when you're coding too. Look back and see, are you capturing what you're really doing in your treatment session, or are you missing something? Are you coding for one CPT when you're actually performing and documenting a different code? And then are you utilizing more than one code in a treatment session, which is fine, You just need to make sure that you are utilizing both those codes. Your documentation supports that. And then it's important to know that there are certain codes that do require a modifier when you put them together, but that's going to look much more from a medical billing standpoint. So as a therapist where I work, we do have a medical biller side of things. So of course, it's the therapist's responsibility to know their CPT codes, to document, to support that, to pick the correct ICD-10 codes. But then our billers are, the ones that are responsible for going ahead and adding those modifiers. So if that is something that you needed to do yourself, you would want to make sure that you got that information to know what codes billing together would need a modifier. So incorrect coding, we're going to move into for a little bit the HCPCS level 2 billing. So again, we are using the same treatment principles that are relevant to our license and our discipline. When we utilize equine movement within our treatment, the basis and framework of it is established on the dynamic systems theory, sensory integration, motor learning, all of these other things that we've learned before that we utilize, and the same practices and procedures that we're using when we're treating a patient in the clinic. So we're not creating a whole new standalone service. It's going to be important, and we'll talk later, that when you look at your documentation, that it looks like, just in my case, since I do serve in a pediatric outpatient clinic, that it looks just like the pediatric outpatient clinic note for somebody else. So we don't want to be using a code that isn't correct and that isn't one of those CPT codes. So the S code, which is the S8940, labeled equestrian therapy or hippotherapy, was originally created and introduced by commercial insurance in 2005. But it wasn't ever supported or driven by therapists or the need for it. AHA has never recommended it. It really has come up as a way to, on the insurance side, to capture what they thought was this service. And it continues, I can tell you, to come up, because every time we think it doesn't, it seems to pop up again, and we hear of people asking about using it, or what it is, or is this a new and appropriate code? So I can say that in our experience here, that specifically it came around again in the fall, where we had a big clinical bulletin that released this code and that pushed, for reimbursement with this code. And that really came about from the fact that NC Medicaid went to 5 different managed care providers. And during that transition, now one of the providers sent out a clinical bulletin announcing this, and that it was an appropriate code to utilize when using equine movement. So when you look at the definition of this, it says equestrian therapy, hippotherapy, also referred to as equine assisted therapy or therapeutic horseback riding, describes a treatment strategy that uses equine movement to engage sensory, neuromotor, and cognitive systems to achieve functional outcomes. Hippotherapy has been proposed as a therapy for patients with impaired walking or balance. So again, this definition itself is putting us right in there with like therapeutic riding. It is leading all with the equine, so equine assisted therapy, therapeutic horseback riding, things that we are not performing when we utilize it within our treatment plan as a PT, OT, or speech therapist. So in addition, if that wasn't enough to say, like, we're not ever going to want to use this code because it doesn't define what we're doing as a skilled clinician. The other why not is that if you look at more how medical coders submit claims, the general usage of it is that there's going to be the 3 different code sets when you submit it, and if you're using an HCPCS level 2. So there would be the CPT code, which would be what the provider did. Then there would be the HCPCS code, which would be what the provider used. And then there would be the ICD-10 code, which is why the provider did or used it. So this would fit more of the example of, because once again, we're talking about the HCPCS level 2, it's talking about like DME, other supplies. So it would be more of when you might need a medication for a different procedure that a doctor would do, or a piece of equipment that you needed in order to provide that service. So once again, it would not be appropriate to be utilizing this as a HCPCS level 2 for billing. And where it falls under the actual, because the HCPCS are all, like I said, starting with a letter, so you can look up all the different HCPCS level 2s. Where it falls within there in the S codes, it's actually labeled in the miscellaneous supplies and services. So that again does not effectively describe what we're doing. And then the other part of it is that a lot of times HCPCS level 2s can be described or are described as experimental. So if you do a search on PubMed or another research database, that you'll come up with, specifically on PubMed, over 400 articles that include hippotherapy or equine movement. So at what point does something become no longer experimental? So, you know, where is that definition? Is this really experimental? We have research behind it. And then lastly, you never want to use a HCPCS code level 2, or, well, in this case, the specific S code, or any code that's created for equine blank, even for a denial, because the more you use a code, even if it's for you to gain a denial for whatever reason, the more and longer that code is going to stay around because it has support and it's been in use. So hopefully if we just stop using it, excuse me, then we will eventually, I would like to say, see it go away. But as I had said, in our experience here, we constantly seem to see it, you know, every now and then pop up on clinical bulletins and other recommendations from insurance companies to utilize it as a billing code. So when we look at billing, it's important to understand the difference between in-network versus out-of-network. So when you're in network, then you have you as the provider have signed an agreement and a contract with an insurance company to provide services for them. In that contract, you've agreed on a reimbursement rate, and then you as the provider directly bill the insurance company to receive that reimbursement. So when you are looking at in-network insurances or payers, then you need to look at always verifying benefits and looking at possible pre-authorizations or whatever that insurance company requires. So when we bring on a new patient, it is standard practice that before we ever see them, we verify their benefits. So when you do that, when you check their eligibility and benefits, you want to make sure that you take a record of that too. So you want to record the name, the department, the person you spoke with, the date and time, and then also ask for a case or reference number. The most, you know, backing you can have on this and the most documentation is important. You want to ask for things that are relevant to obviously what you're going to be providing. So for physical therapy, are there physical therapy, or if you're OT or speech language pathology benefits? You want to see what are the exclusions on these services. You also don't want to ask if hippotherapy is covered or if it's an exclusion, because once again, we're not billing for hippotherapy. We're not billing for equine anything. We are using a CPT code, which is within our discipline, in order to provide the treatment that we're providing and to reach our functional goals. So asking just if they have any exclusions. You want to make sure that you know if there's any pre-notification or pre-authorization requirements. This is also going to be important even if you have two insurances. So if you have somebody come in that has a primary and a secondary, and you're in network with both of them, and the secondary requires a prior authorization, you still need to make sure that you're getting that prior authorization before you start services, because otherwise you're not going to be getting coverage for that secondary payment from that other insurance provider. You want to go ahead and know what documentation is required by the insurance company. So what do they need from you in order to get, if they have a prior authorization process, or in order for you to bill for reimbursement? You need to know things like, what is the deductible and has it been met? That determines how much your patients will be paying when they come and receive services. And you want to also know, is there a copay and how much is that? So these are important things to know so that you can also work with your patients on how you're going to receive payment from them, making sure they understand, even though it is their insurance company, what they're going to be responsible for when they come to your facility and receive their services. There also is when you can bill out of network. So when you look at out of network, the provider does not have a contract with the insurance company. They can offer the patients the chance to utilize their services with out of network benefits. And then you as the provider would have to create and provide a super bill for the patient. So what happens for that is that the patient pays the provider in full, so you as the therapist in full, and then you provide them with a super bill, which is essentially like a receipt, and they can then provide that to their insurance for possible reimbursement. So the things you would need to know to make sure that you provide on there are going to be the provider's name, address, phone number. You're going to have to also put on there the provider's tax ID or EIN number, the date of service, the amount charged, the CPT code, which are the procedure codes that we talked about, and then an ICD-10 code for your diagnosis code and treatment code. And then the reimbursement for this is also going to depend on the individual plan. So again, it is advised to call the insurance company and know what is a benefit or what are their requirements even out of network. Because the more information you know going into it, the easier it's going to be to set that up with both your patient and yourself and your facility. So moving on to documentation. So again, what we've talked about since the beginning is that we're going to focus on the therapy. So once again, we are still going to be looking at what are we doing as a PT, OT, or speech therapist? And that's going to drive what our documentation looks like. So many times when I bring therapists on and then I start auditing their charts or helping them with documentation, I run into the issue of seeing a lot of terminology or sentences like what I see on the screen right now. So backwards sitting, horse, things like that, and or whatever directions we used while we were on the horse, or the more common ones that I think more people are moving away from, like mount and dismount, but doing good at bringing that terminology out of there, but then also making sure that we really keep our hats on as therapists as what we're doing. It doesn't necessarily matter what school figures I'm doing. What am I doing that for is what I need to be documenting in my notes. So again, I mentioned earlier that if I was audited, my notes really need to look like another pediatric therapy clinic in my area. That's really what my documentation should be looking like for a physical therapist. So some examples like backwards sitting. For this, maybe, you might be looking at billing or the CPT code of 97530, therapeutic activities. So maybe a sentence to better describe this could be therapist directed pelvic tilt with slight anterior trunk lean for facilitation of upper extremity weight bearing through extended arms in order to increase upper extremity strength and increase independence with self-dressing tasks, including completing zipper activity. So once again, trying to look at what the function is, how you're relating that back to your coding. Not that I needed to, that you needed to document backwards sitting, because what is that doing? Same thing with a lot of times working on grasps. I see a lot of my occupational therapists talk about holding the reins to steer, or turn or pull or whatever. But once again, looking at that focus of what you're doing and why you're doing it. We also talk a lot at my facility about internal notes versus notes for billing and documenting your actual skilled therapy. So a lot of times we know our patients go on certain horses for certain reasons, or that we use certain tech with them, or, obviously at our facility, we have a policy about gait belts or safety belts around them and helmets. So a lot of my OTs always like to put in that they put their helmet on, they put their belt on. And in those notes that go to, support your CPT code, I don't need to see in there that you put your safety belt on or that you put your helmet on, unless maybe you're working on, fine motor grasp or the strength to release that clip, or that you're working on the motor planning to be able to put the belt around you or maintain your balance. Unless it's a part of that skill and function that you're working to on your established plan of care, then it shouldn't be in that note that's going to insurance or that could be audited by insurance. So another example that I thought of to put on here was horse with increased concussion or crossing ground poles. For that, maybe a speech therapist might be looking at 92507. So treatment of speech, language, voice communication, and or auditory processing. So for this, looking at the sentence instead, saying therapist facilitating increased proprioceptive input to increase erect postural alignment for increased breath control and sound production. And then something like spirals for elongation on the shortened side. So for this, maybe we're looking at the CPT code of 97112, neuromuscular reeducation. So for this, the reeducation of movement, balance, posture, proprioceptive for sitting and or standing. So therapist facilitating right lateral trunk elongation and weight shift for increased erect postural alignment and control during sitting tasks. So again, really just this slide to get you thinking about how you're currently writing your notes and if that's going to be supported by the insurance company if you ever get audited. Is it going to look like you're providing therapeutic writing lessons, or is it going to look like you're providing interventions that are supported by your CPT codes and that are then helping you achieve your functional goals that are established within your discipline and your scope of practice? So again, using proper coding for services that you are providing. Think about, are you utilizing more than one CPT code again? And that's fine. You just want to make sure that you're capturing that for billing and for your documentation. And again, using your daily note to justify the CPT codes that you are billing for. So your treatment should be addressing your established goals from your plan of care, because we're working towards our functional goals within our discipline. And you should be obviously addressing at least one goal each intervention, or spending time to address and work towards each of your goals, depending upon how many in that specific client and what your plan of care is. And then the important way to go ahead and make sure that you are justifying your CPT codes in your notes is going back to the SOAP format. So the SOAP format gives you 4 components, which provides you 4 different opportunities to really support the code or codes that you're using and tie that back into the CPT code with that verbiage. So your subjective, which is the S, would be looking at statements about the patient's relevant status that week or since you last saw them, or behavior. Commonly would include how the patient is feeling that day, how they felt after your last session, a description of their symptoms. The O, which is the objective, would document the measurable and observable and quantifiable data from the treatment. So your range of motion, manual muscle tests, other special tests and scores. And then your A for your assessment when interpreting the meaning of the S and the O. So interpreting the meaning of the subjective and the objective. You want to investigate here, how did the treatment session go? You also want to have, you as a therapist want to be documenting here the why. So as the therapist, here is where your clinical reasoning needs to be and your decision making, as well as any patient comments throughout the session. So you want to look at why is a skilled therapist required? Did you provide cues to the patient? Did you provide them with assistance? Did you direct or correct movement or activity? Did you notice improvements or limitations in their performance? And you want to compare this to their last treatment session. How did their performance in the clinic activity that you facilitated go, and how would it translate into their performance at home or community and their ability there? And this is where you need to look at in the assessment to address really, again, the what, the how, and the why of the therapist, as well as the takeaway and assessment of that treatment. And then lastly, the P, which is the plan. And I mean, I've been caught in this before where we say continue with updated plan of care. So it's important here to really use this section also to take a little bit more time to document better here. And the better you document better here, the less problems you could have when you're audited, because again, you're going to take this opportunity to use this section and support your skill and the CPT code that you utilized. So the plan would include things like plan for the next session, may include your short-term goal, long-term goal, prognosis, and recommendations or any changes that you would need to make moving forward. So just a basic example of, a SOAP note really focusing on these different things would be the S. Sally is happy at an initiation of session today. Can we play outside today? Mom reports she is asking, can we play outside today? Sorry. Mom reports she is doing well this week without changes, but that she fell yesterday when trying to step up a curb. So again, we're addressing, what she feels like. She's a kid. That's what I work with. So what she might say coming in, how her attitude was, any changes since the last one. We hear are reporting here that obviously probably curb work as a PT is something I'm working on. So a difficulty she's still having. And then O, facilitation of a step stool task requiring Sally to step on and off a 7-inch step in order to increase her independence and safety with stair negotiation. Sally was unable to complete 7-inch step up or down without experiencing a loss of balance. So objective. Then for the assessment, Sally was unable to step on and off a 7-inch step without experiencing loss of balance 50% of the time. She required upper extremity support of 1, as well as verbal cues to increase anterior weight shift and proper foot placement throughout the task. Repeated trials improved stability, with Sally requiring less cueing for motor planning, but further training is recommended to improve safety while completing stepping tasks. Continued progression of balance, training, and strengthening is required for safe navigation of steps. So reporting again what you did as a skilled clinician and justifying your need to be in that intervention and your need to continue services. So lastly, it kind of reiterates, but in the plan, continue with established goals on POC, but elaborate on that and say, focus on continued progression of balance training and strengthening required for safe navigation of steps. Work on single limb stance for increased control and stability when completing stair and stepping activities. So now that we've talked about documentation, how to relate it back to what you're doing for your CPT codes and the importance of that, we're going to look at some common documentation mistakes. So documentation is going to be so important when it comes to reimbursement, because it really allows you to get it reimbursed from third-party payers. So when you're looking at things that might distract you, when you're making your notes or documentations or not paying as much detail to it to make sure that they're accurate, that's when you can make mistakes, which then can trigger denials, which then can trigger attention from CMS or third-party payers, which then can lead to an audit. And when you get audited, a lot of times you're opened up for looking and discovering many other errors that might have occurred, and then looking at recouping reimbursement that you might have already received. So it's really in your best interest to make sure that you're taking the time, again, to understand your CPT coding, to know what your scope is and know what your functional goals are, so that you can really choose those correct ones and then document it strongly, so that this doesn't happen. If you've taken, I know in the Part 2 AHA course, they talk a lot about different denials or typical denials that might come up if you're utilizing equine movement in your treatment plan. One of the things I know that they educate clinicians a lot about is that you're marketing. So for that, you want to make sure that you're actually marketing again what you do. So not everything is horse, horse, horse. I know that, where I am, of course, everybody knows that Shining Hope Farms provides equine movement as one of the things in our facility, but it is not what we provide. We provide PT, OT, speech. So making sure that your marketing also reflects what you're actually doing and not just with the horse. Otherwise, that's one of the ways that you're opening yourself up to be investigated and then might have reimbursement or having audits that cause you to lose money and have to pay back money. Another thing is the inaccurate coding or describing the treatment and billing for it. So there is no, again, billable service as hippotherapy or equestrian therapy, like when we talked about the S code. That is not a standalone service. We are not hippotherapists in the US. We are not doing that. So again, making sure that your coding is correct and that you're describing in your treatment and your documentation what you're coding and billing for. And then I would say failure to understand and correctly challenge health plan exclusions or denials. So you really need to understand your health, your third-party payers. You need to understand what their requirements are. And then if they give you a denial or they request more information, you need to understand specifically what they're asking for. Sometimes it has nothing to do with the fact that you are including equine movement within your treatment. You might just assume that. A lot of the stuff we receive here is really teaching therapists how to have that strong documentation that a lot of our insurances here require prior authorization, and they might get a request back for more information needed. It has nothing to do that we might be utilizing equine movement if appropriate with that patient. It's the fact that we didn't have strong enough documentation to justify that insurance company giving us reimbursement for those services or giving us those authorizations. So making sure that you understand and educate and have that relationship again with your payer source. So you need to have a good knowledge of that, and most of the time it's very different depending upon the third party. So again, knowing your payer source and knowing what their requirements are. Common documentation mistakes. So a lot of things that we see that we might have issues with getting reimbursement or having our documentation hold things up are missing certifications, re-certifications, or prior authorizations, missing or incomplete documentation, minutes and units not matching, and then questionable medical necessity. So the first one we're going to discuss briefly is the missing certifications, recertifications, or prior authorizations. So again, like I said on the last slide when we started talking about this, is know the insurance requirements. So this is going to be different for different third-party payers, but you need to, again, be checking that eligibility and benefits of insurance company. So I will say that, like here, our billing department checks every single month for the eligibility of our patients who are on Medicaid, because in North Carolina, we have a big issue that now that we have 5 different managed care providers, they literally might change every month, or because if they don't make Medicaid requirements anymore, they might lose their Medicaid. So it's important that you are staying on top of eligibility and benefits, because if they lose it on the first of the month, or they switch insurance companies and they needed a prior authorization for that, then you're going to be out all of those visits until you discover that that happened. And then, you know, having good communication with your families. We've run into before that families change jobs, families change insurance. Once again, even if it's a private one and not Medicaid, if you switch and you haven't checked eligibility and verification of benefits, then you could be out all of that reimbursement until you figured that out. So we have a policy where we ask every single day, you know, when we see them every visit, have you had any changes to your insurance? And then, you know, when you're looking at that eligibility again, are there PT, OT, and speech benefits? Are there any exclusions within them? Things that also come up are there a limited number of visits for one of those disciplines? Or are you sharing in all of those units? We have some insurances, some patients that come to us and their insurance is a big pool of units from PT, OT, and speech. And so we have to figure out, you know, if they're getting other providers when those units run out, and then the different requirements we might have to do, because some insurances, when you run out of units, you then have to get that prior authorization. So again, knowing the third parties and the insurances you're billing, knowing the documentation requirements that they have, knowing your copays and deductibles again, and then of course covering your bases and making sure that you document anytime you talk to them, a reference number, a call number. And then if you get a prior authorization, having that in writing. You always want to have a copy, you know, a lot of them fax it over or, you know, give you an authorization number. All of them will say on there, it's not a guarantee of payment, but you need to know and have that number. You need to also know that it's your responsibility that when you obtain an authorization, you need to know what units were approved. So how many, if you are billing units, how many that gives you, how many visits are approved within it, and is there a time frame for it? And then if you need to obtain a reauthorization, you need to know when you need to go ahead and apply and do that. So some insurances might give you 6 months with the visits all in between. Some might give you 6 visits. It once again depends on the insurance. And then again, you know, not asking if hippotherapy is an exclusion. It's not a standalone service. But it is important to note that if there is a specific exclusion in there for hippotherapy, that it isn't recommended that you bill while you and actually utilize equine movement in your treatment plan, because you're just putting yourself at greater risk if you're audited and they do see that you're utilizing equine movement, because they have a specific policy in there that excludes it. And there is a agreement between you know, the insurance company and the individual receiving the insurance benefits. And then of course, if you are in network with them, you have that agreement as well. So a lot of this comes back to educating. I would say a lot of the issues that we've had before with insurance in the past, because we're in network with all insurances except Medicare at my facility, is really just being able to educate them on what we're providing and showing them the research of it and showing them that it isn't horseback riding lessons. And there's a difference between therapeutic riding and, you know, again, showing that education and staying within your scope. And then again, if you are out of network, that you need to go ahead and still be able to provide the family with a super bill if they want to try and go ahead and recoup expenses. And then know your discipline regulations. So even if you have direct access within your discipline, that doesn't mean that you should go ahead and provide services without a prescription. Third-party payers will typically not, I actually don't know of any that will reimburse for services when there is not a doctor's order. And again, making sure that your doctor's order reflects what you're doing. So your prescription should be just like any other physical therapy, occupational therapy, speech therapy, language therapy prescription would look like within your discipline. This, if you need extra clearance because of utilizing equine movement or you have other concerns, then you need to go ahead and obtain that separately. So for billing and reimbursement issues, you should have your standard, just like any other outpatient facility, or what one you would be comparable to, a prescription that would read just like theirs. As far as the next one we're going to review is common documentation mistakes, is the missing or incomplete documentation. So when you've been seeing somebody on your caseload for a while, not having good updates for progress in there. So if you're updating a plan of care, you need to be specifically documenting the patient's progress towards their established goals. So documenting a treatment or just a standardized test, but not interpreting it, is not enough. So you need to use that information to evaluate the patient and their progress. And then make recommendations from there. So you need to take that information and you need to modify, discontinue, achieve, or upgrade and downgrade goals. As far as, you also need to be looking at prognosis. So you need to be giving professional judgment on your patient's future and what your judgment is on where they're going to go from here and what the recommendations are. And then the other thing here would be minutes and units not matching. So again, this isn't going to be very relevant for speech because their CPT codes are not time-based, but sometimes we've had issues, and this will flag things in the system, is if you don't have an EMR system that automatically, like most of them do, match their units with your minutes. If you're doing CPT codes that are time-based, occasionally you will have issues or glitches obviously in the system, or you will have systems that you use that you have to put in your own minutes and your units, and they don't just automatically transition over together. So you need to know what units are for each minutes value as well. So you need to know that you can bill for a CPT code for 8 minutes or more. And then knowing the ranges, whether you would bill 1 unit, 2, 3, or 4. So you can go ahead and also know your cutoffs, because if you accidentally put in there 51 minutes, but you bill 4 units, then that's going to be flagged because your minutes don't match your units. In addition, this is important for you to know as a clinician if you're looking at reimbursement, because if you put 52 minutes in there, and if you would add 53 minutes in there, you would have a whole nother unit of reimbursement if you're using a PT or OT CPT code. So again, those are some things that we've seen get kicked back, or that therapists that aren't familiar with billing minutes and units or CPT codes have had issues coming in and doing, not understanding that difference in the units or the minutes to match them. And then the last one we're going to talk about here is questionable medical necessity. So I would say, again, most of the things I see kicked back from therapists is that we're not documenting the medical need enough. So really having a strong documentation to show the patient's medical need for services and what your skilled intervention is going to be. So obtaining, again, physician prescription and an ICD-10 diagnosis code and treatment code with a detailed evaluation indicating PT, OT, or speech services. You want to go ahead and determine your best interventions and treatment tools that will meet the patient's needs, and have that on your plan of care also. You want to go ahead and have a strong clinical rationale for utilizing equine movement as a treatment tool. So I know, where I work, once again, everybody knows that we have horses and that we can utilize that when appropriate for a possible treatment tool. However, there are times, I think we all know if we've been practicing this, that it is not in the best interest of the patient, or that it would not be that beneficial. So we're not going to let the tool dictate what our services are going to be. So once again, we need to have that strong clinical rationale of what our patient needs, our reasoning for it, and what our functional outcome is going to be for the treatment tools and techniques that we utilize. Your best practice is always going to be that your pros outweigh your cons, that you're looking into any possible contraindications or precautions in that area. And then again, that your documentation should include the verbiage from the CPT code to really support and tie in your note for billing and to show that medical need. So that concludes our presentation for the Back to the Basics presentation for coding, billing, and documentation when we're professionals incorporating equine movement into our treatment plan. So I guess at this time we can go ahead and open up for any discussion or questions that you guys might have.
Kelly, you want to go ahead and stop screen sharing?
Oh,
and then that way we can have everybody's who is wanting to be on, so we can see your faces. Feel free to go ahead and turn on your cameras. We do, Kelly, have a couple of questions already asked, and then so I'm going to go ahead and ask those, and then hopefully people will either write in the chat or, as long as we don't have too many people trying at the same time, go ahead and just unmute yourself so that you can ask the question. But Kelly, one of the questions we've been asked is, will you be providing a PDF of your PowerPoint presentation?
I believe they'll be I think they usually post it on the AHA website, correct,
Okay.
Carol? So I think the other Lunch and Learns, so I have no problem, providing that to the office so that they can go ahead and put that on there. Yes.
Great. The second question related to that, Kelly, is that your examples of how to document accurately were very appreciated, but of course that was not on the slides. So how might people be able to access that type of information to have some references?
I guess, is that in reference to the one of like not using as much of the horse?
So like the one where you had the patient was rear facing.
Yeah, that one.
Mm-hmm.
I don't have I can also add those in either to the slide, like the example of, I can tweak that slide before I send it to Adria, and then that way it can be up there.
Okay, very good. Thank you. Those were the two that I had heard, but I'm imagining that people are going to have more questions. So If anybody does, again, just feel free to unmute yourself.
I had a question, and I'm sorry, I'm going to chime in real quick because I have a client getting ready to start. We have had some kind of confusion between multiple facilities that offer the same kind of services, and there's been some dispute between in like the summary or where you're listing your recommended interventions, whether you put in the use of equine movement or whether you kind of like she had said in the notes, you're not really stating that as much as what you're doing as either pelvic tilting or, that kind of stuff. So do you recommend putting into your plan of cares that you plan on using the use of equine movement or?
So the way I do it and the way we've done it here and trained is that we go ahead and I do list it in there. I list it as like equine movement, and it might be in there with other, obviously my other things that I'm going to use. So like handling techniques, parent education, like we do have a whole section on, our evals where I do include that. So yes, we would be including it. No way in this presentation, and am I trying to this is not a presentation about hiding or not saying we're doing something. It's purely to try to get everybody to remember that keep your hats on for what discipline you're in, because the constant struggle I have when I bring therapists on board is that it's like we're doing something totally new and different. And I'm like, try to keep that same thought on when you go out into the arena and utilize the horse, because yes, there are those internal notes we need, but you need to document it like your whatever discipline you are. And so to say that also in my SOAP note, I do say, utilize equine movement for neuro re-education. So, or whatever it is I'm, for that specific client or my discipline. That is what I put. I do equate it to like, if I put somebody on a therapy ball, I was going to say, or like a peanut ball, I would say it one time, or the Bosu ball, I would say it one time, but then I talk about what I did that was skilled, really going back to the basics of a SOAP note, like how did the patient react? What was I looking for? What did I direct? So once again, I'm saying what I did, but then I'm just focused on what I did and why and the skill of it.
Okay, perfect. Awesome. Thank you.
Okay, Kelly, we have some more questions. How many codes are you billing for a 45-minute session?
So that would be three units. So you could, it would depend on what you were doing again. So you have to look at it. What am I doing in that time? So you could be doing, for me as a PT, I might be doing 97530 for 15 minutes of it. And then 30 minutes of it might be 97112. Or you could break it down anywhere between there that meets the 45 minutes. But again, you have to remember that 8 minutes. So like 2 units could be 23 minutes all the way up to 30 minutes. So you have to have at least 8 minutes in order to make a unit. Does that answer that question? Whoever had it.
If it didn't, please let us know. There's another question. We are out of network and provide super bills. Do you have any guidance on the code of place of service, such as 11 versus 49?
So we do use 11 for all of our billing for both. Now actually I can't answer that for super bills. So I take that back because we are in network with everybody. So we no longer provide super bills. But our location that we always bill for in network is 11. The only company we're out of network with is Medicare, and we're actually looking at getting in network with them. But we haven't billed anybody with Medicare that's been out of network.
Thank you. That was my question.
Okay.
Yeah, we just updated our super bills, and we've had a lot more families ask us that their insurance companies require POS. And so I was just looking at the CMS guidelines, and I just didn't know, like 41 or 49 just says if no other POS code fits.
Yeah, we do.
One.
We
And
definitely
therapy. So
We definitely do 11, and I would think that for your super bill, you would do it the same, because
Great.
essentially the only difference between the super bill and then you billing like the provider, or you billing as the provider, is that you already have a contracted agreement. So you're pretty much providing them with the same information. It's just that they can then go ahead and apply, for that reimbursement themselves. So that really is the only difference. So I would say you need to keep it as accurate as you would do if you were going to be billing.
Absolutely. Okay, I'll keep 11. Thank you.
Okay, so the next question was from Victoria, who I see has been able to turn on her videos, so she may have a follow-up to her original question. Do you use a billing or documenting company?
We do. So we've tried several different ones over we use ClinicSource is who we currently use. We then went and because they're not the most expensive out there, but they're not also the cheapest. So then we tried to go to a less expensive one, and it really didn't work out well. So I would advise that one, I didn't like it from a therapy side of things. I didn't like the documentation options. But then it ended up being very difficult for our billers too, who are going into the system to use it as billing. So I would recommend that, obviously you have to look at what financial capabilities you have, but going for the cheapest, EMR system out there is not always the easiest. So I would say ClinicSource has been pretty good for us for both the documentation side of things and then also for the billing reimbursement side.
Is that is it excuse me, ClinicSource, CLINI?
Clinic.
Source?
So
Clinic.
clinic, yeah, like CLINIC, and then
Okay.
just one word.
Okay, great. Thank you.
Okay, so the next question, Kelly, we know it's going to get a little sticky because this is going to be dependent state by state, and you're only going to be able to answer for North Carolina. The question is are there specific codes for billing when the services are provided by a CODA or a PTA? And again, this was specifically with Medicaid in mind. And then the question was, or even if a CODA or PTA can provide services to Medicaid patients. So again, we realize this is state by state, so you can answer for your experience.
So in North Carolina, we're able to have PTAs and CODAs provide services. And once again, this is, like Carol said, a state by state thing. So if you guys had specific questions on that, I would refer you to your state boards that regulate those disciplines, because you'd be able to find all that information on there. Both like for, so like I could go to NCPT or NCA, OT, licensing board so that I can find out what the supervisory requirements are. So like in North Carolina for PTs, we have to be able to provide so many direct on-site visits for those patients. We obviously also, because of our scope, are the ones creating the care plan, evaluating the patient. We are the ones doing the authorizations also for insurance. And the OT is about the same here too. So the only difference there is that they don't require direct supervision. For their board, it's general supervision. So that is determined on a experience and then also on what the comfort level is between the therapists. So because the OT here actually has to sign off on the CODA's license. So their license, in both cases, the therapist license is liable if anything goes wrong. So you also have to know really your therapist and what their comfort level is, what that assistance experience is. And, when we look at bringing somebody on, since again, we're just in the niche of pediatrics, I look at, do they have peds experience? Because if they don't have, if they don't have any clinical experience, that's a huge barrier to overcome, because I have to have you very strong and clinical before we can start incorporating equine movement. If they don't have peds experience, then I know they might need more help, from the therapist. So really deferring to your practice acts and what is allowed in the rules and regulations for your state.
Okay, next, can you describe internal notes versus your insurance notes, such as your SOAP note? Is the horse and equipment listed on these and not the SOAP note or therapy documentation? Are they fully separate?
So yeah, I wouldn't say we have a ton of like internal notes where I work unless I know somebody's going to cover for me. So if I have we do try to cover for each other if somebody's going on vacation or has a planned day out. So that's kind of when our internal notes would come up, and it would be, hey, like, this patient, and it'd kind of be like, I would think when I wasn't, my peds setting, when I do early intervention and somebody covers for me, I already kind of give them a lowdown on what the patient is. Maybe they really hate this. Maybe they start crying when we do this. So it's kind of that same thing. It's a very informal, like, this is what we typically use. This is the horse we're on, that sort of information. Where I'm at also, we have a master schedule, and our master schedule has a lot of that information on it. So it already has on there the horse. It already has on there the tack. And this is also important for us because we are a PATH facility. So we already track all of our horse usage and the times and the number of times they can go a day. So that's really, our internal note process is very informal. And it's more of a communication as needed between therapists. Or, if there was other horse personnel that needed to know, like for our horse usage, we need to have our program director that maintains the horses know who's being used when and how many times. And then of course, our SOAP notes, we want to make sure that those are showing our skilled services. We don't want to look like, at our facility, we offer mental health. We also offer therapeutic riding. We also offer recreational riding. I don't ever want my physical therapy notes incorporating equine movement to look like if I was actually using my CTRI riding instructor, or one of my therapeutic riding instructor's notes that they have to do. I want it once again to be comparable to somebody that would also be treating a pediatric population, because that's what we're offering where we are. So again, not hiding that we're using the horse at all. Like, I don't even want that to be a thought. It's that we're staying very focused on what we're doing, why, and tying it back into function, and making sure that our CPT coding is supported in our documentation.
Okay. Gloria just had a comment that she now only works in pediatrics, and because she did not bill Medicare, she got dropped from being a Medicare provider. So she's just letting people know that that might happen to you if you're not using that. And then I have one last question in the chat so far. Can you provide an example of pediatric prognosis you would put on a progress report as a PT?
I mean, a lot of times I talk about, it's very case by case basis, but it would have to be, Sally has good rehab potential due to her progress to date. Sally in the last 6 months has achieved 3 of her 4 functional outcomes. And then I specifically list at prior, at last gross motor assessment, Sally, blah, blah, blah. Like, I literally put, what she could do if I was doing stairs. And then I put, now Sally is da 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 da. And then I literally spell it out. And then I put goal number 2. Sally is this. Now Sally is this. Due to Sally's progress to date, due to her parents' participation at the end of therapy and ability to carry over recommendations of home exercise programs, due to her improvement in XYZ, I have updated and progressed her to higher functioning gross motor goals, including da 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 da. I expect in the next 6 months that we will be able to achieve these goals because, and then of all the information I already supported. So it's hard to give you an exact example, but things like that is what you need to put in there. And then I would also say making sure that your goals are obtainable. So you're gonna run into issues getting authorizations. You're gonna run into issues with reimbursement if you're not setting achievable goals. So it's huge in pediatrics. Like, I'm not having people come in with fractures. I'm not having people come in after surgery. I have to know what is a feasible goal for them. And then I have to write those goals and justify why those are important. So that when I come to that mark of reauthorization, I can say I've achieved those goals. Because if I've achieved 0 of my 4 goals, they're not going to care what I write. they're not gonna give me any more visits. So yeah, and then also having your families buy into that, like that's super important, because if you're writing goals that the family could care less about, I know that equine movement is effective. I know that what I'm doing is skilled, but my 1 hour a week is not going to be the make all break all. So if I'm not having parents that are buying into what they're carrying over at home, I mean, even in adult patients, if you're working on a goal because that's what you think they should do, but they don't care about it, then you're not going to make progress and you're not going to meet those goals. And then you're not going to be able to get your authorization or your reimbursement because you're not making progress. And I would say that this is important for even when you're not billing insurance, because once again, even if you're doing fee for service, even if you're looking at grants for funding, once again, our reimbursement, where we get our reimbursement from doesn't guide our practice as clinicians. We should be providing the same level of, care and the same CPT coding and all of that, regardless of who is paying us. So, and that's not only important for, our ethics and our licenses and our boards, but also your malpractice insurance. Like, even if you have, even if somebody is paying out of pocket, you're doing pro bono, you still should be getting a script. Like, if something happens, you're not going to have the support of even a doctor's order if you didn't do that.
Hey, so continuing on the vein of the progress reports, how often are you doing them, Kelly? In Michelle's facility, they're striving for every 12 visits to review progress and update goals.
So I would say that we typically, most of our patients, well, now that it's managed care, it really varies. So I will say that typically we try to do it every 6 months. Is the longest we'll push it out. Some are every 6 visits, which makes it really, really hard, but that is because it's driven by the authorization we get from insurance. So we have them everywhere from 6 visits to 12 visits. I would say it's the next most frequent 16 weeks, and then 24 weeks, which is 6 months. And then we do an annual eval or re-eval every year. North Carolina Medicaid requires that you do an annual eval every year. I will say it's also important, if you guys are billing insurance, that too, I think I mentioned it, and if I didn't, I mentioned it, or I thought about it when I made the slides, is that you need to know if they have 2 insurances, that you need to make sure that even if it's the secondary insurance and it requires an authorization, that you get that authorization. Because if you have, like, a lot of kids that might have, a private as their primary and then Medicaid as their secondary, if you're not going to get reimbursed by that second insurance, you're going to get a denial if you didn't get that prior authorization before you started seeing that client. The other issue we run into a lot here is that we have patients that might start receiving our services when they've been at another facility or clinic, or they want to try to do both. So I would say, as a PT, if I'm in that situation, 1, I need to believe it's medically necessary that they need a second visit of PT a week. Otherwise, I am not bringing that patient in. The family will have to choose, do they want to transition to my care, or do they want to keep their other PT provider? It's also important to know that when you're picking up that patient, when was their last PT evaluation? Because if their last PT evaluation was last month, their insurance is most likely not going to reimburse your PT evaluation. So you need to know that as well. In that case, you would probably have to go off of it, and it's very annoying and doesn't make sense, but would have to make a care plan off of that other PT eval. I know people have a huge issue with this, but if you just think again like a therapist, you as a PT should evaluate somebody technically speaking, the same as another PT would evaluate them. That doesn't mean that when I first see them, I'm not doing my own assessments, that I'm not doing my own evaluation in my head. But as far as billing and documentation, I have to go off of that. So yeah. And if you add in a second time a week, you need to collaborate with that PT. You can't be overlapping goals. Or whatever discipline you're in, whether it's OT or speech, like you have to come up and once again, that goes to the medical necessity that, you would be able to have other goals that they're not already addressing and that they would need you.
Kelly, I'm going to ask a question before I continue to ask these others, just an offshoot of what you just said there. is what if you don't agree with the goals? How do you handle that in a evaluation and plan of care that's already been established?
So I will, if they're transitioning to me, Carol, is that what you say?
Yeah.
I will develop my own plan of care.
Okay.
I will not just necessarily take their goals.
Okay. All right. I know you don't use super bills, but the question was, are modifiers also related to super bills or just for billing insurance directly? Do you know?
I don't think they should be, because it would be an out-of-network one. So it's not going to be going through like a medical system like we would be doing. That's more for like the medical coding side of things. So I don't believe it would apply to super bills. And there aren't that many codes that need a modifier. So yeah.
What percentage approximately of reimbursement are you now receiving? Realizing that you have many insurance companies that you're dealing with. And what is the going rate, if you can share, for services in North Carolina?
So that is, once again, we're in network with everybody. So we have a contractual agreement with each insurance provider that we're in network with. So I can't really answer that because each insurance company or third-party payer is a different amount. And then also your CPT codes reimburse for a different amount as well. So it's not just like we talked about all this CPT coding. Each of those are worth a different amount of money, and each unit is that amount of money. So that's why it's really important to know what your units and minutes are also, because if you miss the next unit by 1 minute, you've essentially lost, I don't know, maybe like some of our codes are like $26.50. So you've essentially lost $26.50 dollars just because you didn't spend 1 more minute. So, I mean, I get you have to say, you know, I see 8 patients a day back to backs because I see 32 a week, and then I work my EI job and I'm clinical director. So, I mean, I get staying on time, but if it comes down to like 1 more minute, I'm going to be over 1 minute, and I probably will be over a minute all day long, or 5 minutes over all day long. So just understanding that, because that really, you know, helps you. And here, my plan is to see everybody for 4 units. So it's not like I'm using the system to try to get that money. I'm just aware of it so that we make sure we're recouping what we're planning on it. Because you're also, you know, here we pay horse leaders. So I get paid, and we put the money into paying horse leaders so that we know that we have somebody that's consistent, that is able to handle the horse. So, you know, you have to keep all of that, the big picture in mind.
Okay. So Sunny is asking because she says they're out of network providers. So would you suggest that they be sending documentation such as evals and progress reports to the referring physicians? She says most of our doctors write a prescription for 1 year and don't request records in order to write a new one for the next year, although we do have the documentation to support it. Our families are the ones who request the new referrals or prescriptions.
We don't send ours off even, and I don't imagine we would change that if we were doing super bills. You know, I am very conscientious if I have a medical concern, and that, you know, I might need extra clearance for something. If anything could be a possible contraindication, I'm very good at communicating with our doctors and then getting that in writing as well. I'll usually type up a letter saying like, I'm a physical therapist. Here's my goal. I'm seeing your client. Here's what this is going to entail, because a lot of them don't understand what equine movement is, because I've actually had doctors, you know, clear somebody and I'm like, there's no way I'm putting that person on the horse because I know it's contraindicated. So I'm very clear with the doctors what my concern is, but that I, you know, obviously in that case, if I'm reaching out to them, I still think it's okay. So I say, I think that, you know, if you're in agreement with this, please sign this. So as far as documentation with doctors, I'm not having them sign the evals or that, but I don't think that would change if there was a super bill. I only think the different communication would be is if I had a medical concern and I wanted to go ahead and get that extra clearance. And in that case, I'm very specific what doctor I send it to also. I don't just send it to the primary care doctor. You know, if it's a seizure concern I have, it goes to the neurologist. If it's a kid with hip issues or concerns, it goes to the orthopedist. So I don't just send it to their primary care doctor, who is usually the one that's signing off on my scripts.
Okay, I've come to the end of the questions in the chat. We're getting lots of thank yous, Kelly. However, if anybody's been sitting here waiting to ask a question live, please feel free to ask.
Can I ask a quick question? What about like, are you guys in network with some like the national companies like Aetna and some of the others and they have like policy bulletins against, specifically hippotherapy?
Yeah, so that goes
How do you-
back to, yeah,
And-
that goes back to that, I don't have any current patients with Aetna, and I know that they're one nationally. We were just talking about this at the course the other day, Carol. But I think hopefully we're going to be targeting that with the reimbursement, AHA. So yeah, I mean, it's a very tricky situation because I think it's a lack of education and knowledge. But we need to have that, without putting yourself at increased risk, we need to have that changed. So yeah, it's
Yeah,
really
I mean,
hard.
they talk in their policy bulletin, they equate hippotherapy and therapeutic riding.
Yes.
It's
That's,
like,
yeah. So that's the problem. And that's the problem with the S code, like we were talking about this the other day in the part 2 course too, is that I think a lot of the S code also is reinforced because there are people trying to like bill for therapeutic riding and stuff that is not a medical service. So I think that some of the reinforcement of the S code and stuff like that is coming from that. But I really think it's a lack of knowledge too. Like we were also talking in the course over the weekend that no matter how many times I tell somebody something, like they're leading first with equine or they're saying hippotherapist, and I may see a patient for 5 years and still correct them. And yet they're still referring back to that. So I think it's really hard to get that clear education out there. And really people to understand, like, we're not reinventing the wheel. We're not doing something totally different. We're not doing pony rides. So yeah, I think that's just a battle. And I would say if you guys specifically have issues, of course you can find me, my email, and I will be happy to help, with anything I can answer. But then also, I know HA has the reimbursement committee, so I know they're always willing to take questions or things like that. So.
thank you.
Okay, so there's one other question that came in. Is there a list of national insurance companies that have exclusions? Because of course we're all familiar with Aetna. I personally am not familiar with any other national company that has an exclusion. And then she just mentions that of course there are the task forces state by state.
Yeah, I don't know of any other ones, and I don't know of a national list that lists any that would be excluded.
I think Aetna's really the only one we're aware of. And there was a woman who took the part 2 this past week who's very knowledgeable about insurance and billing. And she stated that when she looked at the Aetna site, it hasn't been changed in a very long time. And that actually, it needs to be updated. So she's going to be helping us with that.
They claim, I just looked at it, and they claim that it was being revisited in January 2023, but it obviously has not, because they were still stating that as if that was in the future. Yeah, I mean, I happen to know, I personally have Aetna, and when I looked into, whatever, they love to exclude lots of, I mean, standard clinical speech therapy. I mean, I had 2 of my own kids that all their speech therapy sessions were denied. I was like, how do you not cover speech therapy? It needs to be from an acute change. It was.
Oh, yeah, we have
yeah,
some insurances that we really struggle with. So I have a big problem with Optum. So yeah, they look at it all from orthopedic, like it's all orthopedic authorizations. So yeah.
All right, so Sunny asked, is there a list from the state task force in California? I don't know how we would know that.
I don't. I'm on the opposite side. So I don't know that. Um,
How do
Yeah, I
you
was-
handle long-term, oh, sorry.
Oh, I was just gonna ask, because I know there's the state task forces, like, you know, Colorado and for all the states that are looking for those exclusions to try to talk to the state assembly or talk to the insurance companies.
Absolutely.
But maybe if the AHA state task force has a list of those by state, then maybe we could be better, you know, better prepared and more knowledgeable for our potential patients.
And I think that's great feedback because we were talking the other day
Yes.
about, once again, in the course that we just hosted here. That's why Carol and I like the other day at the course. Just about really coming together more like unified and working, you know, so I think we're gonna, well, especially with her joining the reimbursement committee, I think hopefully some of that stuff will keep happening.
Yeah, and I do know that task forces themselves are made up by healthcare providers that are within the state. So those lists would be kind of changing on a pretty regular basis as to, you know, who would be serving on them. How do you handle long-term patients with limited change?
So I'm going to say when I evaluate somebody, I talk about discharge. So, we're having that conversation from when we start, that this is not a lifelong service. Now that doesn't mean I don't see patients for a long time. And that also doesn't mean that I don't discharge patient for maybe 6 months or 10 months or a year and then pick them back up. But yeah, I think it goes back to really looking at small slices, like some of my kids that are really involved, you know, looking at that tiny, tiny slice of where we're going to achieve that goal, and making sure that that's our goal as opposed to a goal that we're not going to achieve in that timeline. So I would rather have a kid that, you know, if I'm writing a plan of care for 6 months, I would rather have a kid that in 3 months, I'm like, wow, we've achieved all my goals. Like I can update that plan at any time. And then when I have to re-auth them, I can say, hey, I already updated these goals. Now these are my new goals. So like, even if I haven't achieved those ones that I added on, but that's the beauty. That's the part of like your plan, like anywhere in your plan along the way, if you're a therapist, you can add a goal. So I think it's really just looking at those tiny slices, like how, you know, if you're looking for me, if I'm looking at rolling for a client, like they might not be able to roll all the way from their back to their stomach, but maybe I can get them to sideline. You know, they might not be able to be the kid that's going to be able to sit up all the way on their own, but maybe they can reach their arm up and across their body or push through their elbow and start to lift their head so that they can help their mom when they go to get up and get dressed. So like I'm looking, and it may not even meet that, you know, it'll be how much assist, how much percentage of the time. So really breaking it down. And then it makes it really easy to update my next plan of care because I can say, oh yeah, we did this. Now it's going to be, instead of 50% of the time, it's going to be 80% of the time, you know, or with how much assist. So I think I think it's hard to say that because it's such a case by case basis, but I would always say like err on the side of caution, because when you update your plan of care, it's going to look much better to say you achieved them all. And then you can also at any point in time, you know, upgrade those goals.
Awesome. That was the last question that I had. And Sunny, I apologize if it seemed like we were shortening time for your answer. Just know that AHA has assisted individuals. They have certainly gone to those state task forces. I know they've changed. They've made changes in a number of states, and, you know, Medicaid and insurance related changes. So if you were to deal with a particular insurance company and you were having issues and you weren't able to resolve them, that is what the committee within AHA is there for, to help you. Hey, any other questions? Right. Well, Kelly, you have been an absolute wealth of knowledge, and thank you so much for this presentation. I think this was the best attended Lunch and Learn that AHA has hosted to date, and you know, certainly the most questions. So obviously, Kelly, do you feel comfortable sharing your contact information should anybody have
Sure.
Further questions?
I will type it in the chat if that's good with everybody. And then, of course, I'm pretty sure I'm on, I don't know, there's still the lookup on AHA, right? Like for HPCS or something. But yeah, if anybody needs it and it's not there, but I will type it in here now. Right.
And then while Kelly is doing that, just to let you know that I do believe in May, there's going to be a lunch and learn that is going to be presented on how to submit a presentation abstract for AHA conference. So knowing that the conference is coming up in March of 2024 in Jacksonville, that if anybody is thinking about giving a presentation, that you'll want to be planning on attending the May Lunch and Learn, and obviously you'll be getting more information about that date. All right, well, thank you all so much for attending.
Yes, thank you guys.
Thank you.
Bye.